Welcome to the UNC Core Center for Clinical Research Speaker Series. We appreciate you taking the time to join us for our presentation this morning. And we are really happy to welcome Dr. Armaghan Mahmoudian, who is a physical therapist with a joint doctoral degree in biomedical sciences from KU Leuven in Belgium and VU Amsterdam. She's currently an assistant professor in the Department of Movement Sciences and Health at the University of West Florida in Pensacola, and she's also a research associate with the Department of Clinical Sciences at Lund University in Sweden. Dr. Mahmoudian's research focuses on the early identification and secondary prevention of knee osteoarthritis, including post-traumatic OA. I have personally had the pleasure of working with Armaghan in the last couple of years, and I'm really excited for you to hear about her work in early stage knee OA. So Armaghan, whenever you are ready.
Yes, thank you so much, Amanda, and thank you for having me today. It is my pleasure to talk a little bit more again about the definition of symptomatic knee osteoarthritis at an early structural stage. And I don't know if you noticed, we have changed that a little bit from early stage symptomatic knee OA to bringing that concept of what we really mean by EsSKOA here. So I'm going to talk a little bit about that change, the rationale for developing a classification criteria, the progress to date, which you've probably heard a little bit about on the ORC webinar, and then some of the challenges we're facing. So here's our disclosures, and I'm just going to turn off my camera just in case my internet gets shaky. And before I move on, I would like to thank our sponsors, our generous sponsors, Viatris and Grunenthal, for all their support during the last 3 years, without which we wouldn't be able to move this far. So let's start with thinking about why do we even need an EsSKOA classification criteria? Well, I think it's obvious for all of us here that osteoarthritis is a serious disease and a major cause of disability worldwide. And routine average OA management typically targets patients in relatively later stages of the disease and illness. And despite decades of clinical trials, we still have no approved disease-modifying therapy. The past failure to develop DMODs is due to many factors, of course. Some of them include heterogeneity of the patient population and complexities of the disease process, but maybe also the fact that we're still enrolling patients based on the 1986 ACR classification criteria. But to remind you, patients fulfilling these criteria have advanced disease with manifestations such as chronic pain, major structural changes, biomechanical alterations, and just simply saying too late. Before we move on, it would be useful to separate illness and the disease because it helps in the context of our conversation here. Illness is what patients feel, like pain, impairment, loss of participation, and disease is what we measure, like the structural manifestations. In many cases, in a way, illness comes before the disease. If we only classify by disease, we might be too late. And importantly, FDA and EMA require that interventions impact like how a patient feels, functions, and survives. And this is why treating early symptomatic OA is justified, even if the benefit is symptomatic before structural changes. I think you're familiar with this one. I'm just going to go over it very briefly. Looking closer at this, the development of OA represents a continuum from healthy through the asymptomatic, at risk, to early stage knee OA, established OA, and then end stage OA. The blue and black lines here represent the clinical illness and structural, which is the disease course, respectively, which could be accelerated in the presence of predisposing risk factors for progression. And of course, we are aware that not all patients follow this path. Some of them will never get to the end stage or progress, and they will follow a pattern of inertia, which is not shown here. At the symptomatic early stage of the disease, there are no or only limited radiographic detectable structural changes, and these patients typically present in healthcare with intermittent activity-induced knee pain and/or symptoms. This is the stage that could serve as a window of opportunity to slow or arrest the OA disease process and restore joint homeostasis. Like in other rheumatology conditions, OA likely has a window of opportunity as well. And we've seen this shift succeeded in other diseases, like in rheumatoid arthritis. The development of early classification criteria allowed patients to be identified and treated much sooner, which dramatically improved long-term outcomes. In axial spondyloarthritis, the definition once required radiographic sacroiliitis, but which meant like many of these patients waited years for diagnosis. But recognition of non-radiographic axial spondyloarthritis showed that the same disease construct could be identified earlier. So it's not a new construct, it's just identification of it earlier, even before X-ray damage appeared. And here the lesson for OA is also clear. Like we should not wait for visible damage before acting. Again, another concept that helps with our discussion today is separating classification criteria from diagnostic criteria. The classification criteria are standardized definitions intended to create well-defined, relatively homogeneous cohort of patients for clinical research. They are not intended to capture all patients with a particular condition, but rather to have high specificity, few false positive at the expense of false negatives, in contrast to diagnostic criteria, where both the specificity and sensitivity need to be very high, therefore more suitable for use in clinical care. So, again, going back to the first question, why EsSKOA classification criteria is needed to define a research-ready population, people with knee symptoms and a high likelihood of early OA, early stage OA, before advanced structural damage happens. And this lets us run earlier therapeutic trials when benefits are most detectable. Test current symptom treatments in this early group without waiting for radiographic OA, and use a standardized definition to drive biomarker discovery, risk stratification, and identification of likely progressors. One important caution as we think about early stage symptomatic knee OA is the risk of overdiagnosis and overtreatment. When someone presents with knee symptoms, we have to be careful not to medicalize every case of knee pain or expose people to unnecessary treatments. So the challenge is balance, intervening early enough to make a meaningful difference while avoiding overdiagnosis and overtreatment. This is why precise classification criteria like EsSKOA are so important. And of course, OA faces unique challenges. We don't have a biomarker like urate in gout. Progression is slow and variable. We still don't fully understand when and how OA begins. There aren't many cohorts of early symptomatic patients we can study, and knee pain has many mimickers. These challenges make development of classification criteria for EsSKOA harder, but also even more necessary. To address this, in 2021, ORC launched an initiative to develop classification criteria for early stage symptomatic knee OA, partnering with a diverse international group of scientists and clinicians with a vast background in OA research and classification criteria development. So what is the big picture? The objective or the big picture is that we're expanding what counts as symptomatic knee OA to include an earlier stage before X-ray damage shows up. The end product is a research classification tool, not a diagnostic test, a simple score with a threshold that lets us consistently identify the right early stage patients across sites, enroll them earlier in trials, and give disease-modifying therapies their best chance to work. So we're not coming up with a new construct. It's just identifying symptomatic knee OA earlier before the structural manifestations appear. So who are we targeting? The target population for EsSKOA classification criteria are individuals with undiagnosed knee symptoms. The aim is to identify EsSKOA patients regardless of whether they will eventually progress to established OA or not. These criteria are not designed primarily to predict progression. Their purpose is to provide a clear, clinically meaningful foundation for research. So step one is to establish the criteria themselves, defining who belongs in this early symptomatic group. And step two is then to study these individuals prospectively to understand the variability in both symptom and structural progression, and to identify what determines who progresses and who remains stable. It's also important to remember that symptoms matter. People with early OA deserve treatment for their pain and functional limitations, even if they never develop advanced structural changes. Progression in OA is not only about cartilage loss or radiographic findings, it can also mean worsening symptoms, declining function, or reduced participation in daily life. So how does it work? When it comes to development of classification criteria for OA, there is no gold standard, no biomarker like you're rating out to define symptomatic early stage knee OA. And as I always say that, well put in the RA literature, expert opinion is so embedded with the use of the 1986 classification criteria that there's a danger that using such judgment, only that judgment, could cause the elements from the original classification criteria appear to be also important in the new one. So what is the solution? The solution is using a combination of data-driven analysis as well as expert consensus approaches, which is the ACR-ULAR framework that we are following for now. The goal is to find the most concise combination of factors that, when applied to individuals with undiagnosed knee symptoms, can accurately identify those with EsSKOA. This includes, first, generation of a list of candidate items that should be considered in development of the criteria. So the first part is just piling up all the factors potentially important. Phase 2 includes data collection and analysis to examine the ability of the candidate items that we collected in Phase 1 individually and in combination to discriminate people with EsSKOA from other causes of knee symptoms, which are mimickers, but also from individuals with established knee OA. And then in Phase 3, informed by the evidence generated in Phase 2, a consensus-based decision analysis process will be used to identify those factors as well as their relative weights that influence the probability that an individual has EsSKOA or not. And finally, in Phase 4, we will conduct refinement and validation. Let's begin with Phase 1, which is the phase that we already completed. So Phase 1 is very crucial phase where we really want to ensure that we broadly consider all the potential candidate items. So things like demographic characteristics, symptoms, signs, and diagnostic tests that could be useful to classifying an individual as having EsSKOA. We wanted to make sure anything potentially relevant has been added to our bucket to be able to look at it more closely in Phase 2. So we gathered diverse input through a series of studies involving patients, health professionals, and researchers. And given that we wanted the eventual criteria to be widely generalizable, we ensured that a global representation of the perspectives are considered. And these are the 5 projects we've completed for Phase 1, and I'll briefly go through these studies one by one. So we started with a scoping review of more than 200 studies. We wanted to map how early stage knee OA has been defined in the literature and which elements were used to define it. Definitions were highly variable, as you can see on the right side of the screen. About 70% required imaging, most often KNL grade 2 or more, which conflicts with our EsSKOA construct, symptomatic OA without established radiographic changes. So this misalignment showed existing definition wouldn't serve our purpose, so we couldn't start from any of those definitions already. We therefore extracted most frequently used elements within each domain to take forward into the Delphi exercise for structure evaluation. So you will see through these studies that we took these items from each of these studies, put it in our bucket. So we're just piling items now. Just make sure we included everything that is remotely even helpful with defining EsSKOA. Now, for the next study at ORC 2022 in Berlin, we conducted a live survey and then followed up by ORC newsletter. We presented a case scenario of a middle-aged woman with knee symptoms. Respondents rated factors increasing or decreasing the likelihood of early-stage symptomatic knee OA for this case scenario. Activity-related pain and stiffness emerged as key symptoms, and 1/3 indicated they would obtain an X-ray likely to exclude mimics, especially established OA. And we carried these frequently endorsed elements forward into the Delphi candidate item list again. So starting from the systematic review, scoping review, we got our items. Here we also collected the highly rated items. And we also wanted at this stage to include patient perspective. So we also conducted a qualitative study to explicitly incorporate patient perspective into the item generation. We used focus groups and interviews from 91 individuals with knee OA, which was collected at Orsi-Omeract effort in 2006. So we did not collect this ourselves, and these are not early OA patients. They were already diagnosed with established OA. Qualitative description yielded 4 themes. First, insidious onset with gradual intermittent symptoms over years. Second, heterogeneous first symptoms. Some had stiffness, some had crepitus, some it was just pain. So we knew that the symptoms in the beginning are really, really heterogeneous. Early dismissal or rationalization of the symptoms. They would say, oh, maybe it's because of an injury that I had, I don't know, 20 years ago. They wouldn't want to believe that it could be like a chronic disease like osteoarthritis. And then finally, compensatory strategies that maintained activity until they failed. And that's the only time that they seeked help. And that's where we would find them in the clinics, right? These patient-derived features informed our subsequent survey, which you will see later. And we added some patient-generated items to our candidate pool from here as well. So here you see the bucket that we started with. And then here we piled up a list of these factors, and then we ran a 3-round international modified Delphi with OA clinicians and researchers to expand and modestly reduce our phase 1 item pool. We didn't want to do the item reduction in phase 1, but if there were items that were not getting through phase 1, we were happy to remove them. So in round 1, 128 experts from 5 continents reviewed candidates, the items that we provided them, and nominated additional items. So we looked at it, and items with 3 or more nominations were added. In round 2, experts rated items useful on a scale of item usefulness on a scale of 1 to 9. In round 3, they viewed their prior rating plus group medians or quartiles, and if they wanted to re-rate, they could re-rate their ratings. Then we retained items with median of 5 or more out of 9, which yielded 66 items. But looking at those ratings, it was interesting because it's very different by discipline. So a pre-specified subgroup analysis, we did a pre-specified subgroup analysis by discipline: rheumatology, orthopedics, primary care, physical therapy. And then using the same threshold, we retained 11 more items, in total 77 items to move forward with. So the bucket you see here has 77 items that we moved forward with. To further embed patients' perspective in phase 1, we ran an international survey of people with knee OA to characterize initial symptoms, complementing the clinician researcher Delphi that we did. We included only respondents who could recall their first year symptoms and used free text responses. 92 patients participated, 1/3 were within the 5 years of onset, so it was different from the first survey that we analyzed. They most described changes in how the knee looked, felt, and moved, aligned with the Delphi highlights that we already captured. But notably, 50% reported early effects on overall well-being, like anxiety, sleep disturbance, fatigue, indicating these features are integral to the early illness experience. So we also took those factors and added to our bucket, as you see on the right side. The final study of phase 1, so this is not about piling up items anymore, but it was a necessary study that we did. It was so we wanted to see who are the mimickers. So we wanted to understand the conditions frequently in clinicians' differential diagnosis or EsSKOA. And these would be the conditions that would be critical to include in our phase 2 cohort, since we wanted to understand how well candidate items discriminate EsSKOA from mimicker conditions. Now, in our survey of 127 clinicians across a range of disciplines who provide care for people with knee OA, we confirmed several key conditions that were frequently used as a differential diagnosis, including most frequently immune-mediated inflammatory arthritis, crystal-induced arthritis, patellofemoral pain syndrome, bursitis, meniscal tear, and ligamentous strain. So phase 2. Phase 2 is the item reduction stage. We're analyzing phase 1 candidate items to quantify how each of these items increases or decreases the probability of EsSKOA versus mimicker conditions. The goal is to create an evidence base to guide expert decision in phase 3. Item weighing, scoring, and threshold selection, which is the phase 3. So we're at phase 2 now. For phase 2, we needed data sets that include people with undifferentiated knee symptoms, both EsSKOA and likely mimickers, and that capture our phase 1 candidate items. So we needed cohorts with mimickers and established OA, as well as the ones having all the factors that we captured in phase 1. First, we decided to leverage existing cohorts wherever possible, but keeping in mind that many lack sufficient early cases, mimickers, or the full item set, which we call it secondary data analysis. So we separated into primary data analysis and secondary data analysis, because in the secondary data analysis, we figured we don't have we do have established OA patients, but we won't have early OA and mimickers as much as it could help us in the existing cohorts. So we knew we're going to need primary data collection as well, which is currently in progress. So for the secondary data collection, we looked at the cohorts available for OA, and interestingly, it is obvious that our pilot for the secondary data collection is probably going to be among the 4 classic OA cohorts, the OAI, Check, Most, and the JOGA. And we're moving forward with that one. For now, we're mapping those. But in this phase, what we will do is that we will solicit case submissions from clinicians across disciplines and regions, distinct from phase 3 expert panel. So these are going to be experts that are not participating in phase 3 expert panel. Cases will include both EsSKOA and mimicker presentations, and they will capture the full phase 1 candidate items. So any factor in our bucket has to be included in those case scenarios, creating an external heterogeneous test set. In the absence of a gold standard, as is often the case in rheumatology, a proxy definition is required, such as the physician's confidence in or level of certainty about the diagnosis, as used in other rheumatology criteria. So here we're going to go with the same concept. We're working on the protocol for our adjudication process, which will happen both for the derivation cohort and the validation cohort. The classification criteria will be developed, or at least the preliminary classification criteria will be developed in phase 3. First, we will identify a clinical panel of clinicians from diverse backgrounds, including clinical disciplines and geographic locations. We're looking for clinicians with experience assessing people presenting with undifferentiated knee symptoms. The expert panel will review a subset of the submitted cases, as you saw in the previous slides. They will rank the probability of each case of having EsSKOA versus a mimicker. This process will help us identify positive and negative features that are influencing their rankings. Then we will discuss inclusion and exclusion criteria, as well as whether there are any items to allow classification criteria of a patient as having EsSKOA, anything that we might have been missing. And then second, in this phase, we will conduct a discrete choice experiment using a preferences survey. And this is how it will work. The purpose of discrete choice experiments, which is a type of multi-criteria decision analysis, is to identify the features with the greatest influence on clinicians' probability determinations. They will be presented with two scenarios differing in only two criteria, and they will select the one with higher probability of being EsSKOA. Then at this phase, the relative weights of the items are determined through this iterative process. And then the final weights at phase 3, the final weights to produce the scores will be assigned, cases will be scored, and will be reviewed for phase validity, asking this question: do the cases that score higher reflect the construct of EsSKOA? And then, if needed, weights may be revised at this stage. A threshold score for EsSKOA will be determined at this stage also. What it means is that a threshold for appropriate versus inappropriate for enrollment into a clinical trial. So we need to determine that threshold in this stage as well. At the end of phase 3, preliminary classification criteria will be developed. The final weights will determine, the scores will be assigned. So we will have a score of 0 to 100 about probability of having EsSKOA, with a higher score indicating a higher probability of having EsSKOA. Now in phase 4, we will start with the preliminary classification criteria that we developed in phase 3, and then we will do the refinement and validation in an external cohort or external cohorts. And then even once criteria are developed, we still need the regulators to accept early OA as an indication. Other diseases like gout, lupus, RA didn't face this barrier, but non-radiographic axial spondyloarthritis did. But over time, it was recognized. OA faces the same challenge: criteria development and regulatory acceptance, among other ones. With that, I would like to thank you for listening to this presentation. I'll be happy to take any questions.
Hi, this is Richard Loser. That was a great presentation, and this is really, really important work. I'm wondering, you talked a lot about, the patient symptoms. When does imaging come into play, and how is that going to be incorporated into this definition? And potentially, if any, blood biomarkers are going to also be included in the definition of early symptomatic structural OA.
Thank you, Richard, and thank you for your question. So among the discussions that we had during the last 3 years, we've noticed that probably one of the factors that help us at least discriminate EsSKOA from the established OA would be imaging, would be X-ray radiographic manifestations, joint space narrowing, right? Regarding the MRI, the conversation we have right now is on how we can, sorry about that, how we can incorporate it. But that would be a conversation that we're working on, adding an imaging ad hoc group and a biomarker group to decide on that one and to further, because it is a different expertise than defining a classification criteria for sure. So it is absolutely on the table, but we're just thinking about, we're arranging and doing the logistics of groups that can define and help us in that area, in that context. But it is on the table for sure.
Thanks.
Of course.
An unusually quiet group this morning. Usually people are asking all kinds of questions.
Close to holidays.
Yeah, exactly. They'll show up, but they're not going to talk.
Well, I know Matt is going to ask a question. No, Matt? He usually does.
Yeah, right?
No. There you go. Turning on cameras.
Working on it.
Yeah. Yeah, it's I feel like we've been talking about this for the last year or so more often. So maybe that's why a lot of these answers are like these concepts have been already discussed over the webinars and conferences. But there's
Yeah.
still a lot to figure out there, of course.
Guess maybe from a methodologic standpoint, we'll come back to Matt's question just a second since I started talking. Um, did you realize how long this was going to take and how difficult this process was going to be? Because there's a lot of trainees on the call and people that, might think about doing a classification criteria, something.
Absolutely not. I started my PhD on early OA, and that was like back then when Frank Moyton had his own classification criteria, like not his, but like started that conversation about it. It was 2011 that I started a cohort of early OA for my PhD. I thought after all these years, we should probably know something about it. But every time, every step we take, there's like a lot to think about. There's like a lot to figure out what would be the best way to move forward from here without making mistakes that we haven't thought about before, and going back and forth with that. So even phase one taught us so much, and it took 3 years. Took 3 years, and then one of the challenges we're facing right now definitely is not having early OA cohorts in knee, or I would say for hip as well, or hand as well, right? So I don't think that was a big challenge for other rheumatic diseases. They started this conversation way earlier, so they started having all these data sets that they can study. But for now, I think this would be a good start for our community to get together and help each other figure things out that we all can accept and be generalizable. But no, it would take way longer than we expected. Yeah.
Thanks for that. I'm going to read Matt's question in case people are on the phone or whatever. If clinicians are currently ignoring or not treating these early symptomatic patients as evidenced by the need for these criteria in the first place, why would their subjective rankings of case probability be a valid gold standard? Wouldn't a prospectively collected data-driven approach using objective markers and longitudinal outcomes provide more reliable criteria than this sort of retrospective judgment of clinicians that is sort of proposed?
Matt, you wrote a paper?
It's a long question. It's in the chat if you want to read it again.
Yes, I need to break it down a little bit because it's been like really, really long. Okay, if I can find it. Matt, do you want to ask me your question? Because okay,
I think he can't.
Okay.
Yeah.
Here he is.
Can you hear me?
Yes,
Yes.
I can hear you. I'm reading it.
Yeah, I was just curious. It sounds like the phases that you're in right now, you're creating these hypothetical cases of whether, and clinicians rate them whether they are early stage, whether they are EsSKOA or not.
Yeah, because before I forget, these are not hypothetical cases. These are
Okay.
the real cases, and we're not creating them as having early OA. We're just like including all those factors there that we identified in our bucket. We're just like putting there, okay, if someone has crepitus, if blah blah blah, like looking at it, how would you judge this person has close up? So it would be a scale, right? From -2 to +2, and the closer to +2, that would be higher probability. So there will be a ranking. There wouldn't be like literally yes or no.
Okay.
So sorry to stop you there.
And even with that, I mean, the whole reason that we need these criteria means that we don't know how to define what early stage symptomatic NEOE is. That I'm just curious why rely on kind of clinician judgment of whether or not they think the person has early stage NEOA, and why not do some type of prospective study where you actually define some of these early stages that kind of predicts the people that are going to develop the radiographic OA.
So from the primary data collection, I think that would be the case, that because there is no other differential diagnosis, someone has knee symptoms, doesn't have radiographic OA, and that knee symptoms doesn't have to be like just within the last 3 months. It has to be more than that. It has to be intermittent, affects their daily activities, which we don't know the threshold there, but we know that, okay, this person doesn't have any other mimic condition, doesn't have established OA, still suffering, still the quality of life is getting worse. Let's see how we can define this person based on the items that we have. So yes, we don't have a gold standard right now, and you're right, a prospective study would work, but that is exactly what we're doing through our primary data collection. There is no black and white, and there is no right answer for this. This is $1 million question, I would say. But
Yeah, no, I'm not saying
no, I'm just
that you're.
brainstorming about like what we think would be at least a start to move on with this one.
I know you've used some of the OAI data before, but could you use that as a resource too of
For
figuring out different combinations of how, like, different ways to define early stage NEOA?
yeah, as you mentioned, like I've done that a lot before, but
Yeah.
and we're going to do that as well using the OAI in our pilot secondary data collection that we are already working on. But the problem is OAI doesn't include all the factors and items that we have. It does not have, it does have established OA, so that helps us, but it does not have mimicker conditions. And even there, we still have to extract those data that it has, not all the factors, create the cases, case scenarios or vignettes, and then present it to our adjudicators to have the same gold standard like the primary data collection. So yes, we are going to use OAI, but our gold standard is still kind of going to be adjudication, not progression, because we don't want to just look at the progressors. We literally want to define early OA, whoever has it, and then a subset will be the progressors, the second step. So again, yes, OAI helps. Yeah.
I guess I'm still slightly confused on why you don't want to identify the progressors that aren't those the individuals that you would want to target.
Because the concept of a classification criteria should include anyone with that construct, right? With early OA, not all the manifestations, of course, but like it has to define early stage OA, symptomatic early stage OA, not necessarily someone who progresses. So the idea is that we still have to help these people. We still have to give them like a treatment or management strategy. But for now, where are they going to get it? Because they are not diagnosed as NEOA because it doesn't exist, right? They don't have X-ray manifestations. So they're not diagnosed as NEOA. They don't have any other mimic conditions. So they're not getting the help they need. They might not progress, but they still need help. Does that make sense?
I think it sort of comes back to your earlier example of non-radiographic SPA, right? So those people, there are guidelines for treatment of non-radiographic ankylosing spondylitis, even if they don't go on to develop AS. So I think there's two parts to it, right? And I think they will eventually get to the progression piece. And obviously we're very interested in who goes on to get away, but that sort of category of these people that have all this suffering, like how do we address that group separately from, oh, by the way, this one progresses on to get AS or OA or whatever, and this one doesn't.
Yeah, I think I tried to bring that up here to mention that first we need to define what EsSKOA is, and then after that we can study, as you said, prospectively, these population to see who's going to progress and who's not going to progress. And then please remember that there's a threshold as well, like who, with that threshold, above that threshold, they're the ones that we definitely want to put them in the clinical trials. And each of these clinical trials have their own criteria to apply to these patients. It can include MRI or any other biomarkers. So it's just creating that base of a concept.
Yeah, Armaghan, have you thought about the prevention trials that are ongoing now, and they're a few years away before they're going to be finished. But like the top study that Lee Callahan's leading here at UNC and led by Steve Messier, it's a prevention study of women at risk for OA, but they have to have MRI of a knee that doesn't show OA yet. And then there's that Picasso study, ACL injuries and trying to prevent OA. So both of those are studies where people don't yet have OA, and they're going to look to see if they can prevent the early changes, both symptomatic and structural.
That's a very good point. So the way we did our environmental scan of what is out there, we put out a survey and asked like if you're interested to share your data, or at least your data dictionary with us to see if we can use it for the criteria development. I don't think those two are in that list, or at least like got the survey, or I don't know. But it would be really, really good to look at those cohorts. They're really interesting ones. But again, I don't know if it's interesting also for those cohorts to be part of this.
I bet it will be. They're
Yeah.
just enrolling people now, so that
Oh
they're
yeah,
just
I heard about
collecting the
yeah.
data.
It is amazing.
I'm sure they will.
Okay.
And Lee can speak to that too if she wants to.
Right. We've had, oh,
Sorry. No, I just really think this will not be possible without, like, it's not just the EsSKOA or EsSKOA initiative team. It should be like all of us working together on this. Otherwise, it won't happen for sure.
so there's a couple more questions in the chat. One from Jeff Dreben. Have you started to engage with the FDA and EMA to see if they're supportive of this approach to build evidence for the new criteria? Like, will this be accepted by regulatory agencies?
Great question. Not officially yet. Yes. As much as I know. But it will happen. It will happen.
And then another one. Let's see. This is from Ashley Buck. She liked your talk. I'm curious about how valid or accurate some of the diagnostic criteria are for mimicker or differential diagnoses, or are the diagnostic criteria for differential diagnoses facing a similar problem as EsSKOA? Yeah, so like do we know what the mimickers are? Can we define them any more than we can define EsSKOA?
Well, we do know the mimickers, but how diagnostic tests are helping us do that's a different question. So we did a differential diagnosis survey, and we do have a list like the top most common ones. That's a great question. So we had to go over all of these differential diagnosis and develop our own protocol for the primary data collection to see how we can diagnose those and make sure that we have them included, and or at least in our data set for exclusion criteria. But for the existing cohorts, I don't think they're as valid as they're supposed to be. I mean, yeah, I don't think they are. I hope I answered your question.
Yeah, and I think that's often the case. These studies where they, are developing classification criteria for hand OA, and you have to exclude, rheumatoid arthritis and early stage this and early stage that. You can't just apply existing criteria. You sort of have to say within this data set, we think this constitutes this other mimicker. So that's been part of why it's taking so very long, because you realize you don't know things that you thought you knew.
And then sometimes you just have to, from what I learned, at least from my experience doing this, you just have to make some pragmatic decisions to move on, to move forward. And then if there's something that can help you in the future, you will find it, refine it. But at some point, you cannot get stuck, with the same barriers. You just have to move on to find a better solution.
See Liz's hand up. Go ahead. Maybe. You there, Liz? Maybe your hand just went up.
Nice hand.
Yes. Sometimes if I just stick my hand up, my hand will go up. So.
Matt is asking a question. How does pre-OA fit? Are you sending me a direct question or is it a good question?
I think he is. I don't see it in the box.
How does pre-OA fit into EsSKOA? Matt and I have this conversation a lot. How does pre-OA fit into EsSKOA? Why don't you?
Yeah, that was a personal.
It's okay.
I was making a joke.
Yeah.
I wasn't going to
I
ask
know,
you that on
I
there.
know you did. I just read it. I was like, okay, he's asking. Why don't you tell us at ORC 2026? How does that fit?
Program committee didn't want me to.
Okay.
Armaghan,
We
can
do
you
what
hear
we
me now?
can.
Yes.
Oh, there you are.
Oh,
Awesome.
perfect. Sorry, I'm listening from the car and struggling a
No.
little bit, I think, to make everything work. But hey, I just had a question. I can't see. I was listening. I couldn't really see your slides well, but curious how you're handling, some of your mimickers and acute injuries that can lead to OA. How are you thinking about that, and whether are these still symptoms from the injury itself? When does it become, what we're thinking about with early OA? Can you just chat a little bit about how you're handling that within the classification?
Yes, sure. That's a great question. So for now, the decision that was made. So previous knee injury was in the bucket and is still in the bucket, but being able to separate acute previous knee injury or surgery from the actual pain that is related to OA, we decided to exclude those that had injury or surgery for less than 6 months. So they cannot be included. We haven't decided on the frequency of knee pain, but we are including those that have knee pain or symptoms for more than 3 months previous to inclusion, but they cannot have surgery or injury for less than 6 months prior to inclusion. And that is, for now, the way we're handling it. It might change while we're doing our pilot for the secondary data collection. But also there's a little bit of a limitation there because, for example, for OAI, we do not have history of previous knee injury or surgery within the past 6 months. We do have ever had it, but we don't have it as the previous 6 months. But I'm very, very happy if I can hear more about if there's a better way of handling this, because it's been a long discussion between us as well.
Sounds like one of those pragmatic decisions, right?
Exactly. Literally. Yes. Because we know from Matt's work that the persistent symptoms that could be due to pre-OA after the ACL injury, right? So we could not ignore them, but we just thought 6 months would be, less acute, right? Yeah, he's happy.
Exactly. Okay, let me just double check the chat. I don't see anything else. Any last burning questions? Going once, going twice. All right. Thanks so much, Armaghan. That was great. What a great discussion. Appreciate everyone's time. And again,
Thank
this will
you
be
so much.
recorded. You'll get a link.
Thank you for having me, and thank you everyone for taking the time to be here and listening to this. Thank you.
Thank you.